And Dr. Vitull has already introduced the topic, and definitely this is an honor and pleasure for me also to be able to contribute, even if a small topic, at a very basic level, because mistakes are commonly made in this field. That is, when a patient is pregnant. Okay, one recent development that we can Google it out on our mobile phones, that's in a way good. But still, to have a background information, because everything can't be, you can't be Googling every time. And I'm just providing the basic background information. Next slide control, kahan se hai ji? Is this the one? Yeah. So this story actually, just about 100 years ago, no one was fully aware that drugs can have very bad effects on the fetus. So the entire topic came into focus just in 1960, around 1960, when a popular drug, thalidomide, it's a part of history of medicine now. It's still used for certain other indications. But this being a newer drug at that time, it was found useful in early pregnancy for nausea, vomiting, ghabrahat, that means restlessness or even lack of sleep. It was introduced as a hypnotic. It had some anti-emetic actions, and it became popular in Europe. And then there was kind of epidemic of this kind of babies. So this condition is called phocomelia, that means seal limbs, limbs like a seal. That's actually aplasia of the limbs, or very severe hypoplasia of all four limbs. And this was in variable degree when they found it, and some correlation led to this, that this is the drug taken by every pregnant mother in the first trimester who has given birth to such malformed babies. Babies were otherwise fine, but limbs were gone. So this created a great awareness, and everyone then, almost all the doctors became careful, and trials also were started. Even though there's a limitation, you cannot have the standard type of trials in pregnant women, give some experimental drug to a group and give some placebo to a group. That is ethically usually not permissible in pregnancy. That doesn't happen. So again, a difficult situation arose, that how to go about it. But then certain ways were found that we'll talk about a bit later. So now we come to basics about what's the relevance of drugs in pregnancy. Before reviewing this chart, which is very fundamental chart, the problems which can arise is, number one is teratogenesis. Teratogenesis just means structural defects, grossly visible structural defects. Then there can be problems with function. Structure is okay, but then the function of certain organs may get impaired. And then there may be subtle effects which are attributable to a damage. Now, particularly, first thing we are talking about is teratogens. Teratogens are, we know now that not just drugs. Drugs are important, and that's why we are having this talk right now. There are other teratogens as well, like environmental radiation, X-rays, etc., other kind of radiation. Then there may be certain food items, or even non-prescription drugs, or so-called indigenous desi medicine, which most of the times its ingredients are not known, like Ayurvedic, homeopathic people. Those are popular with laypersons, and we don't know, there's no study about those drugs. So teratogens, not just drugs, but there are several other factors. But in drugs, we know quite a bit which drugs are bad and which are good. Now here, uh, if we see, this is just a chart showing the fetal development right from conception onwards till term pregnancy. So early development, the day 1 mentioned here is the day of fertilization, when the ovum and sperm, they unite and a fertilized zygote is formed. That's the day 1, and that is usually taken as the moment of conception. And thereafter there is rapid cell division, we know, and this is around the time of day 14 to 15 of the menses cycle of the lady who is conceiving. So usually the pregnancy cannot be diagnosed at this stage. You know that. Mid-cycle conception starts, and we cannot diagnose pregnancy at that time unless we do very sensitive HCG assays and all. So that's not the part of clinical practice. Then for 2 weeks, it's pre-embryonic development, 2 weeks approximately. Some would say 17 days, some would say 14 days, but anyway, 14 to 17 days till the next missed period. So when the lady misses the period, then she gets her urine pregnancy test done, and that's how usually clinically a patient as well as her doctor comes to know that she is pregnant now. By that time, it has implanted in the uterus. So just as a passing reference, the fertilized ovum stays in the fallopian tube for 4 days. On the 5th day, it goes into the uterine cavity, gets implanted. Still, the circulation hasn't formed. Circulation forms at this time a few days after the missed period. The primitive circulation of the fetus or embryo it's called up to 8 weeks. So after that, the development shown in this chart is that up to 8 weeks following fertilization, that becomes 10 weeks following LMP. Clinically, we can count from LMP only, because not possible for us to pinpoint which day did the fertilization happen, because it may happen anytime between day 11 and 17, which means 14 days, day 14 of ladies' menstrual cycle, plus minus 3 days. That's the time of fertilization. And thereafter, anyway, so then embryonic development, it's very basic thing, which I'm just revising, that up to week 8, 56 days, embryonic development happens, and all the organs are being formed from the totipotent cells of early embryo. All the organs are formed, which is a wonder of life. Almost all living beings develop like this. And thereafter, just the increase in size, the growth of those organs which have taken shape, that happens. Some organs like brain, kidneys, they do keep on forming up to 12 weeks post-fertilization. So I'm just telling you a basic thing is sometimes it's a source of confusion. Pregnancy is counted from the LMP date by the clinician. Clinical doctor will say, ask the LMP, and by tradition, we know that when there is LMP, there is no conception. Conception actually has begun 2 weeks later. So clinical or menstrual age is 2 weeks more than the real embryonic age or biological age of the conceptus. So the crux of this matter is that there is pre-embryonic development, or which is before the missed period. After the missed period, up to 8 weeks from the moment of fertilization is the crucial period of main organogenesis. Some think it goes up to 10 weeks, which is clinically 12 weeks of amenorrhea. And thereafter there is fetal growth. This is again the depiction of the same. Here it shows that this, you can see from the third column, heart, CNS, eye, teeth, ear, palate, all these things form. Whereas brain development does continue up to just the formation. does continue up to 12 weeks post-fertilization, 14 weeks post-LMP. Okay, so thereafter it's mainly the growth. This is still more simplified. I have included it just to show that these are the main periods we got to keep in mind. Pre-embryonic period, then period up to day 8, and thereafter the further fetal period. Up to 8 weeks post-fertilization, it's embryo. Thereafter, it's called fetus by medical terminology. And that tells us that up to 8 weeks is the time, 8 weeks post-fertilization. Again, I'm repeating because it's a source of confusion. That means 10 weeks post-LMP, menstrual age, is the time when there is maximum chance of drugs causing teratogenesis. That means major structural defects in the organs. Thereafter, drugs can cause harm, but that is mainly interfering in the function or growth, general growth of the fetus. So the same thing, reiterating it, that before the 18th day after fertilization, matlab missed period se 3 din pehle tak, when the lady misses her period, even 3 days after that, because circulation forms at that time, from maternal blood and fetal blood, embryonic tissues, you can say. Sorry. During this time, the effect is all or none. If the drug is bad, it's going to destroy all the cells. And that will become a biochemical pregnancy. Just when it's implanting, it will get damaged and very early abortion. Or if the drug is not harmful, it may kill a few cells, but because cells are totipotent, omnipotent till then, so therefore normal fetus is going to develop. So this is about the second half of menstrual cycle of the lady. In second half, we still should be careful because it will not become evident. किसी को पता नहीं चलेगा कि आपने जो ड्रग दी है उससे बेबी का बायोकेमिकल अबॉर्शन हो गया या बहुत अर्ली डेथ हो गई है एम्ब्रियो की, प्री एम्ब्रियो की. But still, we should avoid using in general hazardous drugs which are known teratogens in the second half of ladies' menstrual cycle, because there can be total fetal death without even we coming to know that there was going to be a pregnancy. Next is suppose pregnancy ठीक हो गई, so it's a luteal phase rule इसको बोला जाता है, जो पहले मैंने बोला है, luteal phase rule, or the second half of the menstrual cycle, better to avoid hazardous drugs. Even though no one is going to come to know if you do administer those. So then now the menses have been missed. It's been 2-3 days since menses and pregnancy is clinically diagnosed. That is day 18 post-fertilization. Fertilization is on day 14, and by day 18 after fertilization, that means about 2 or 3 days after the missed period, the circulation is starting. So whatever there is in the maternal blood, that gets transferred to the fetal tissues very well. Before this, embryo is surrounded by the tissue fluid. So that's through the tissue fluid, which is less efficient in transfer of the substance into the fetus. So now this is the main, between day 18 up to 8 weeks after fertilization is the main period, considered to be the main period of organogenesis. So therefore, it's a period for teratogenesis. Teratogenesis means drug causing structural malformation when the organ is being formed. So rarely it may cause spontaneous abortion, but most of the times the drugs cause true anatomic or structural defect. Occasionally it may cause covert, that means which is not manifest or overt, functional defect also. So that's That's why we need to know certain basic facts. Again, reiterating the same thing that in first trimester, there will be teratogenesis or the organ defect, or totally it will get aborted. In the second trimester, developmental defects, especially neurological, which is important. See, brain is what makes us what we are. So, fetal brain may get affected by certain drugs. And in the third trimester, there are different type of obstetrical complications which may result like preterm labor or obstetrical hemorrhage. Now, so we are coming to the main topic that the drug categories were devised about the same time, 1965, 1970. US FDA category A, B, C, D, and X. So, again, in short, I think most of the doctors know about it. The category A is that there are human studies. Human studies aajkal possible nahi hai because of ethical considerations. You cannot have a control group of pregnant women and a test group of pregnant women for a new drug. Ethically, it's not permissible. And category A is that human studies don't show any fetal risk. Category B is that animal studies indicate no fetal risk, but human studies aren't available. Category C is just in the middle of the spectrum, that no adequate studies are there, but no adverse effects have ever been observed in clinical practice or reported. Category D is that there is evidence of fetal risk, either by studies or by clinical observation, but the benefits are considered, benefits of giving the drug are more than the estimated risk. And category X is the worst category, where we know that there are fetal risks, and even these risks are worse than any benefit which may be there. Now, this classification was there for a long time, but then a lot of controversy arose that which drug to be classified as which, because there were certain conflicting studies that you know that many times we get एक fact है, you can get studies in favor of that or against that as well. And the quality of studies in pregnancy, as I've already said, could not be so good because control और उसमें ethical हम नहीं कर सकते. So these were the drawbacks. Controversies arose about the efficacy and safety of many drugs for use during pregnancy. And most of the pharmaceutical studies or pharmacological studies, they started excluding pregnant women just to avoid litigation, because there were certain litigations where companies had to pay a heavy compensation. And then there was some confusion. A, B, C, D. Some people claimed that isko hamari drug ko A mein karo, B mein karo. So all this was cancelled around the 2012. आज से 12 साल पहले this classification was given up. Sorry. So new FDA classification, rather its recommendation. The US FDA then just gave a recommendation that it's will not classify drugs into A, B, C, D, X. Every drug will have particular information which is kind of certified by FDA, and that was called Pregnancy and Lactation Labeling Rule, PLLR, or final rule. That just shows, that just means that with every drug, the manufacturer or the medical scientists will provide a literature or drug labeling which will describe everything about it, every salient point, that means benefit as well as risk associated with use in pregnancy. So accordingly, so just state the facts. Don't say that it's totally safe, it's totally contraindicated. That's what they concluded because of this confusion. So the and along with that, they said that whatever observations are available, in which phase of the embryonic or fetal development are these harmful. That is again pre-embryonic phase जो हमने बात की अभी 17-18 days after fertilization, and embryonic phase up to 8 weeks, and fetal phase 8 weeks onwards after fertilization. And in this, they have to mention that exposure at which stage leads to what. Anyway, so the follow-up is that after about 10 weeks of menstrual age or 8 weeks of post-fertilization age, teratogenesis is less likely, but growth and function of the already formed organs can get impaired. Now, we come to one practical point which is important. See, the teratogenesis is the main concern because it becomes obvious. Everyone gets alarmed that bacha malformed hai. It really doesn't look well. Even those subtle abnormalities of function, even neurological function, may become manifest later on. So this is, for clinicians, it's important to know that in the overall population, okay, I'll hurry up. In the overall population, 2 to 3% babies have significant anomalies. All are not due to drugs. Sorry, 2 to 3% are not due to drugs. There are other teratogens also, genetic teratogens or environmental radiation or certain other factors. Our patients are fond of taking desi medicines. They also may be, they conceal the fact that they have taken desi medicines. So, and therefore, it's really difficult to determine the proportion of congenital malformations which have been caused by our prescription drugs. But still, for example, we know of cases where this Klinefelter syndrome case went to court. They said that the doctor's medicine has caused this. But doctor could easily defend it that this is a genetic disorder, chromosomal disorder. It cannot be due to any drug given in pregnancy at any stage. Then this is a common disorder, a common problem that Ayurvedic or indigenous medicine, Live 52, which may be toxic. They claim that this is not toxic at all, but they don't know really, and false claims are made. Anyway, so what we know already, and we should know, which drugs are really considered teratogenic. This is about phenytoin. So that's why instead of phenytoin of phenobarbital, lamotrigine is now preferred. Fetal hydantoin syndrome. Features are already written. There are pictures on the Google and in textbooks. So because we are running out of time, warfarin, fetal warfarin embryopathy is well-defined condition. If you give warfarin during first trimester especially, you can be held negligent. Okay, why did you give? Because that's why heparin is used in pregnancy. Then alcohol, in our society, very few ladies take alcohol, but this is also a well-defined syndrome, fetal alcohol syndrome. And then this is just a list you will find everywhere, documented adverse effects. These medicines, if you have prescribed in early pregnancy especially, first trimester, then you may be held accountable. ACE inhibitors, you know, carbamazepine is considered safe. Here in this list, they have chloramphenicol is bad if you use it in near term when delivery is due, gray baby syndrome. Lithium, totally contraindicated. Misoprostol is. So this is a list which you will find at most of the. I have just got a copy done from our textbook of a list. This can be distributed. I have few copies, which very well gives you. You don't have to Google it up. It gives all the groups of drugs, commonly used groups of drugs, whether they are safe or not. But my point is that these are labeled culprits. So here, all these ACE inhibitors, ARBs, lithium methotrexate, etc., valproic acid, warfarin, should be avoided. And see, these are the lists I have collected from various sources. In every obstetrical source, you will find these. Now, winding it up, For hypertension, which is a common thing, labetalol, hydralazine, and nifedipine. These three drugs are considered safe in obstetrics at any stage, and labetalol is an alpha plus beta blocker. Beta blockers given alone cause IUGR and certain other complications. So this alpha and beta dual blocker is the drug of choice. Methyl dopa is a central adrenergic blocker which was used earlier, and then now it's not available because everyone started using labetalol because of the recommendations. These are certain other cardiovascular drugs. These are mentioned in the list which I have brought the photocopy. So cardiovascular drugs for various purposes. Anyway, now because we'll skip it because of paucity of time, and you can go through that paper which I've brought. Vaccination. Lastly, vaccinations, very simple. Live attenuated vaccines are risky because they may cause fetal disease. So killed vaccines or toxoids can be given in pregnancy. Live virus vaccines are, which are live virus vaccines? BCG, MMR, and so MMR is not given in pregnancy. And perhaps oral typhoid vaccine is also live attenuated. These are to be avoided. So which can be given? In routine, we can give tetanus. Aajkal tetanus and diphtheria combined, TD, is in vogue. But anyway, tetanus is the routine. Second is hepatitis B. A patient who doesn't know her history of having been immunized against Hep B should be immunized in pregnancy. And third is flu shot. Flu shot also should be given because flu may cause problems in pregnancy. So tetanus, Hep B, and flu, THF, is the mnemonic for vaccines which may be given in pregnancy. And the other one is BCG, MMR, and varicella, which are contraindicated. When indicated, there are three more vaccines which are given to pregnant lady. RMP registered medical practitioner wala, that is for rubella, meningococcus, and pneumococcus. Rubella, meningococcus, and pneumococcus. Rabies, obviously, dog bite. So at any stage of pregnancy, you have to protect the mother. Meningococcus and pneumococcal exposure, or whenever there is indication. Drug use during lactation, it's really not so important because most of the times the amount of drug in the milk is really not significant, but still we can go through the same list which I have provided. And only practical rule which is useful is for a clinician that if she's taking any drug which you have doubt, tell her that take this drugs after feeding the baby. Take it about 5 minutes after feeding the baby, and then baby will sleep for 2-3 hours. So don't take it during that time. So that's about all this about this basic topic. Thank you so much for patient listening.
Thank you very much for masterly talk. In fact, I must apprise the audience that your prescription slip is one of the most detailed copybook style prescription slip, which indicates the mindset of the consultant for research, academics, as well as patient safety.